Okay, welcome everyone. Beranek, I'm president and session. Our first panelist is Dr. Abby Van Voorhees. Abby is associate professor of the Department of Dermatology and director of the Psoriasis Treatment Center at the University of Pennsylvania. And to her right, Dr. Joe Laser Center in, of all places, Maui.
And psoriasis, and we define that as being either moderate or severe disease. So we're not talking about somebody with like the tiny little spot that, maybe they pay attention to, maybe they don't suppose. Of those kinds of patients, about a half of them are dissatisfied with the treatments that they do receive. Treat people, or many people are not receiving treatment for their disease. And then in addition, there's a long delay in diagnosing them. So psoriasis, it's on the skin, you'd think they would notice it, but approximately a third of those patients are not diagnosed and told that they have psoriasis. And maybe that's because they don't seek care, or maybe it's because their primaries don't understand what their skin represents. But about a third of patients are unaware that they, but if left to its own devices, in about half of patients, it causes destructive joint formation. So therefore, understanding that someone has psoriatic arthritis and intervening and initiating treatment is quite important. And we estimate that about 1 in 4 people who have psoriatic arthritis are unaware of their diagnosis, much so. And in fact, women and minorities note this even more, this impact on their bodies. But it's more than just what it does to their skin. We also know that having problems, for example, with psoriatic arthritis makes you feel lousy. I can't tell you the number on board. They'll tell me they know they're ready for the next dose because they feel so run down, like a train had run over them. So that the impact on these people is huge. And then, in addition, both diseases, we now understand, are associated with comorbid diseases, so that we know that people who have both psoriasis and psoriatic arthritis have a much higher incidence of having concurrent medical problems like hypertension and diabetes, and have an increased risk of cardiac disease. We've now recently learned they actually also have an increased risk of renal disease. And this is all independent of other risk factors. So we're not just saying, gee, your patients are smokers, or gee, your patients don't exercise as much as they ought to. These are independent risks that our patients, that we now know our patients are exposed to. So, up until now, there have been groups that try to look at data to try to understand what the true needs of psoriasis and psoriatic arthritis patients are. But inherently, they've been limited in their scope. So, for example, I've been involved personally in a group where we look at, a couple of practices in the United States. Well, that's nice. I mean, it certainly provides some information. But I teach at a medical school, so my patient population is enriched for the most sick patients. So one has to say, really, is my population generalizable to all psoriasis patients? So what's cool about this study that I'm about to tell you about is it was the first really multinational study that was undertaken to look at psoriasis and psoriatic arthritis. And you see on here that roughly 3,400 patients were interviewed. They were conducted in all of those countries. There were 7 countries in total. The Psoriasis Foundation, in addition, looked at 1,000 patients with the same questionnaire. And this was a study that was just recently published in the JAD, and the lead author was Mark Lebwall. And that's what I'm going to speak about for the next couple of slides. So really, in this first multinational study, what we've been able to document is that, again, we've been able to see that patients, that 60% of patients with psoriatic arthritis stated that they were not receiving any treatment whatsoever. So this isn't like a bias of the US system, nor of any individual European or Canadian system. This is really right across the board. The majority, 80%, that's not a small number, of people who have a BSA more than 4, and we define a BSA of 4 as being moderate disease. were receiving no treatment or only topical therapy. Well, I can tell you, when I am in my supervising the residents at the University of Pennsylvania, and I walk into the room and a patient has this kind of burden of disease, if the resident's saying to me, I'm going to give them topical therapy, I say, you know, how about we step outside? Let's have a little bit more of a conversation. So this is not happy news to me. The impact on the quality of life for both diseases is quite substantial. You could see that approximately a quarter of the patients of psoriasis who had this burden of disease we'll call moderate, felt that they had a significant impact on their quality of life, and about 40% of those with psoriatic arthritis. We see that itching, and this is very important because this is something that we in the dermatology community have probably not been paying enough attention to, that itching was the most common symptom that patients were disturbed by. And that was true for both patients with skin disease, so psoriasis alone, as well as for psoriatic arthritis. So, and yet all of our tools that we use in our research protocols, and also, quite frankly, in our day-to-day care of patients, really none of them actually directly measure itch, unless, you know, we just happen to say, are you itchy? So I think that, and also what's very clear is that 85% of patients with both psoriasis and psoriatic arthritis felt that there were a need for more therapies, better therapies, newer therapies to address their needs. So there were some interesting differences. Remember, I started out by explaining to you that there was first this seven country study, and then the NPF also looked at 1,000 of their patients. So if you compare the NPF group, just to highlight that, because I think that's kind of interesting too, we see that the members of the Psoriasis Foundation were more likely to visit their primary care doctors than the seven. I think that, and then a very interesting question that came forward, which is, what are your goals for treatment? And the members of the Psoriasis found another biggie, you know, and lack of insurance can mean that you either don't have insurance or that the insurance really is so restricted, somebody who can help you with your disease, or that the insurer makes it really difficult to access your drug when you want to because of tiering of medications or because of lack of experience and lack of expertise. Other barriers, you know, just a lack of understanding of options. So that's from an access point of view. Oops. From the patient point of view, we still see patients who have both psoriasis and psoriatic arthritis not seeing specialists. You see 50% of people with psoriatic arthritis not seeing rheumatologists, and a third of people not seeing dermatologists. And sometimes it's because they just don't know that they should make that next step, or because their primary doesn't encourage them to do so. And sometimes there's also a problem where patients don't seek treatment. And some of that is that they're afraid of treatments. Maybe they've heard that they're going to cause them to develop cancer or become sick. Maybe they're worried about potential side effects. Maybe they think that they've just been discouraged. They've had experiences in the past where they tried something and it didn't work, and they figure, oh, well, you know, nothing's going to work. So I think that kind of counteracting some of these negative views is something that we really have to work on. Sometimes our therapies are cumbersome. We ask people to come for phototherapy, for example, 3 times a week. Well, I don't know if any of you, I suspect not, but if you've ever tried to park in the parking lot at the University of Pennsylvania, you would consider that burdensome. So I think what we all need to realize is that we're asking a ton of our patients to care for their chronic diseases. And remember, these are things people get when they're young. They're getting these diseases when they're 18 and 20 and 25. So this is a lifetime of burden, not just, you know, your last couple of years of life. Laboratory monitoring is sometimes problematic for some people. And then, of course, proximity. You know, if you live 3 hours away, there isn't a prayer that you're going to come to my office very regularly. And then there's medical needs. Really when we're addressing this, we have to be sure we include all of the variables. And I think while, I will tell you that, if you ask me, I hope I'm taking really good care of my patients, but there's really no clear measure on what defines success. I sort of think I know it. I sort of think my patients believe it, but we don't really have a number, the way other disciplines do. For example, in diabetes, they have a hemoglobin A1C level, and if that number is higher than it ought to be, that's a no, and we don't have a parallel number. And we're just beginning to start to understand that we need to develop that kind of metric. And then there's some disagreement. If I'm thinking how much of your skin is covered is my determinant of the success of my response of my treatments, and you're thinking how itchy you are or how scaly you are, you realize that we may not be talking the same language, and we have to be sure that both patients and physicians are kind of on the same page and that we're working in concert in lockstep. So, and then we need to understand really how good is good enough. I think when we had poor tools, maybe our standards could afford to be low. But now that our tools are better, we have to constantly be saying, can we do better? And is where we are now good enough, or do we need new tools to get us even to the next level? So I think that's something else that we on the medical side really have to constantly be challenging ourselves for. So I think with that, I think it's my turn to turn the mic over for Dr. Martin. Thank you for your attention.
Aloha. Thank you for being here. I'm George Martin. I practice in Maui. I'm a dermatologist, and before I did dermatology, I did internal medicine. I treat a lot of patients with moderate and severe psoriasis of all types. And because we have no rheumatologist, I end up treating a lot of psoriatic arthritis. And I want to share my experience with you. And I want to share with you what a burden this disease places on my patients, and how with really good diagnostic tools and management, we can really help these patients and improve the quality of their lives. So again, it is you all out there who must help us create awareness that psoriasis is really a total body disease, and I'm going to explain to you how. And it's a disease where you have to intervene early, because diagnosing and treating psoriasis and psoriatic arthritis can dramatically improve the quality of your patient's health and overall well-being. About to convey to you is the importance of diagnosing not only psoriasis, but psoriatic arthritis, and the importance of treating early. So psoriasis, how do we make the diagnosis? As a clinician, a dermatologist, in 95% of the time, can simply look at a patch of psoriasis and say, this is psoriasis. When it comes to psoriatic arthritis, the diagnosis can be made on a history and a clinical examination. And 95% of the time, a qualified rheumatologist will make that diagnosis by talking to the patient and examining the patient without the need for a laboratory test. Now remember, psoriasis, there is no blood test for psoriasis that tells us that a patient has psoriasis. There's no genetic test that says a patient has psoriasis. So we have to rely on history and physical examination in the vast majority of patients. Now, we have patients come into our waiting room with psoriasis. But how do we know that they have psoriatic arthritis? Dr. Van Voorhees told us that 30% of patients, 1 in 3 patients with psoriasis, will end up having psoriatic arthritis that in some cases can be tremendously debilitating. So how do we screen for that psoriatic arthritis patient while they're waiting in the waiting room? Various questionnaires have been developed. None are perfect. None are the complete net. But let me share you a good one and a simple one. And let's walk through together these 5 simple questions. Number 1, have you ever had a swollen joint or joints? Number 2, has a doctor ever told you you have arthritis? Now this is a wide net. Patients with psoriatic arthritis would probably answer that if they had ongoing psoriasis associated with arthritis, but also osteoarthritis patients, rheumatoid arthritis patients. They would also answer positive to this question. So more questions are asked. Do you have fingernails or toenails that have holes or pits? And this is somewhat specific for psoriasis. We call it pitting, or oil streaks under the nails, oil slicking. Have you ever had pain in your heel? Okay. Psoriatic arthritis causes a condition and helpful in screening patients with psoriasis that they may have psoriatic arthritis. And remember, 85% of patients with psoriatic arthritis have psoriasis first. So it's imperative that you really identify the primary care physician, the obstetric gynecologist. And so as Dr. Van Voorhees pointed out, and as I have pointed out, this will subsequently develop arthritis. It's incumbent upon us as physicians to then refer to the patient to the expert in psoriatic arthritis, and that's the rheumatologist. So it's collaboration, the patient seeking the doctor identifying psoriasis, once psoriasis is identified, collaboration with the rheumatologist. 3 steps. So what about the importance of treatment of psoriasis on the quality of life? Here you can see this poor individual with a marked burden of psoriasis right there. Normal daytime activities, they're miserable, they're itchy, they're scaly, they're sore, they feel like they have a sunburn. What type of clothing do they wear? Usually they're clothed from head to toe, hiding, the psoriasis on their skin, the embarrassment, the scale. Try going out to a beach on a summer day or going to a pool and wearing a bathing suit when your skin looks like that. It doesn't happen. These patients are depressed. It harms their ability to sleep. I'm sure many of you in the room had a sunburn as a child. Imagine living your life with sunburn every night trying to go to sleep. Not only that, but I also need to help you create an awareness that patients with psoriasis really have an underlying systemic disease. We know that psoriasis patients have a 50 to 70% relative risk of having a higher incidence of stroke, heart attack, sudden death, diabetes, kidney issues. And to put it in perspective, a patient with psoriasis is 10 times more likely to have a heart attack than to have melanoma. Think about that. Severe psoriasis patients, roughly a 4 times higher incidence of them going on to dialysis for their kidney problems than their cohorts. So this is really in many ways a systemic disease with skin manifestations. And vice versa, what we don't know is if treating the psoriasis the moment it develops will ward off these other comorbidities. It's not been definitively proven, but early data show that if you treat psoriasis early and aggressively, some studies have shown an ability to decrease these comorbidities. Further studies are needed, but as you would expect, if you can cut down the inflammation in the body, you will improve the overall risk for these comorbidities. Now let's talk briefly about the importance of diagnosing psoriatic arthritis. Once a joint is destroyed, it is destroyed, and there's no turning back. And so a recent study showed in 100 patients that came into one clinic, a rheumatology clinic, that if the patient was diagnosed and treated within 6 months of the first sign of arthritis, their overall quality of their joints, if they were treated early, was improved than if they waited a year or 2 or 3 later. And it was shown in this study that patients who were treated before 6 months versus those who were treated after 6 months of being diagnosed. Those who were treated after 6 months had a higher incidence of peripheral erosions in their joints, which means destruction. That's what erosions mean. The joint is eroding. They had worse HAQ scores. HAQ scores are a quality of life index questionnaire. How easy is it to get out of a chair, to grip a coffee mug, to hold your spoon, to walk, to drive your car? Impaired if you were not treated within 6 months. The longer you waited, the worse your symptoms. And lastly, radiographic, in other words, x-rays of the sacroiliac area. Remember, patients with psoriatic arthritis also develop spinal disease. About 25% of patients will develop it. So if you have a patient under the age of 45 with chronic back pain for more than 3 months and psoriasis, that patient is very likely to have arthritis. Now, not only is diagnosing psoriasis and psoriatic arthritis very important, and to treat it early, but what we've shown in this recent study, going into an arthritis clinic, a rheumatology clinic, and 100 of the 200 patients were randomized to be treated every month, very aggressively, until they achieved a score, a rheumatology score of improvement we call an ACR 20. So they picked a target before that patient received their initial therapy, and they said, we're going to treat you as aggressively as we can to get you to an improved level of an ACR 20. And we're going to see you every month. And we're going to keep escalating our therapy until we were able to achieve control, until we achieved our target. And that target was an ACR 20, okay? The other group was treated as usually patients with psoriatic arthritis are treated. They were seen every 3 months. The doctor evaluated them and treated them what appears to be not as aggressively. And the outcomes are, as you can see, the patients who were treated with basically tight control had much better improvement in these blue lines of their joints, and their skin was much better improved with tight control versus those patients who were treated every 3 months and not treated as aggressively. So again, we want to find these patients within the first 6 months of the onset of their symptoms. And secondly, we want to identify these patients quickly if they have psoriasis. And then I would say the third point is once they are treated, the treat to target model is proving to be the way to treat these patients. Intervene early, be aggressive, pick a target, and try to get that patient in remission as soon as possible. Now, there's a lot of exciting news about emerging oral therapies, and I want to touch on this briefly. You have to understand that there are many current treatments for psoriasis and psoriatic arthritis, but there is still a demand for newer and better therapies, whether they have better efficacy, better safety, are easier to use so that the patient is more likely to use them. Patients need a wider scope of treatments. Doctors need a wider scope of therapies. We need more tools in our tool chest. So what we've done, as in the pharmaceutical industry has done, and we have worked with, is to create oral therapies that you can see here below. Now understand that these oral therapies are different than the current oral therapies available to treat psoriasis and psoriatic arthritis. They have new mechanisms of action. They're usually pills taken by mouth. They are not a shot. They're not an infusion, and they're usually pills that are given, in most cases, twice a day. And these are a list of them. What this slide is actually, it's outdated by 2 days. As we've recently learned, this molecule, the existing orals, for further information. And thank you very much for your attention, and please, please, create awareness, spread the word, help us help our patients and other patients. Thank you.
Thank you, Dr. Martin. I think our panelists, Dr. Van Voorhees, did a terrific job of giving us kind of the current state of psoriatic disease and its impacts, and Dr. Martin followed on with the importance of diagnosing these conditions early and, more importantly, taking action and treating those. So I'm going to conclude our panel's comments by spending just a couple of minutes talking about what the National Psoriasis Foundation is going to be doing. As an organization, oops, that's back. They trained us on how to use these. See, that investment of time was well spent. For about the last 20 years, the National Psoriasis Foundation has been dealing with psoriatic arthritis. Many of the things that we've been doing as an organization is to invest in research to try and find better treatments, better diagnoses, and ultimately a cure. But we haven't done enough as an organization. And so just recently, our Board of Trustees recently, as of yesterday, made a commitment to ramping up our approach to dealing with psoriatic disease, and I'll talk a little bit more about that. But on an annual basis, some 75,000 people come to the National Psoriasis Foundation for information on disease management related to psoriatic arthritis. As I mentioned, we need to do more as an organization. There's not tremendous consensus on the incidence of psoriatic disease, although it's been well established that upwards of a third of psoriasis patients will have psoriatic arthritis at some point. The burden of disease, we haven't spent a lot of time talking about that, but it's very similar to rheumatoid arthritis, and who among us would not think what a serious disease rheumatoid arthritis is and the tremendous impact it has on people's lives. It's very similar in psoriatic arthritis, and I think Dr. Martin did a good job of pointing that out. One thing that Dr. Van Voorhees mentioned was the time that elapses in diagnosing psoriatic arthritis and the unacceptable period of time that is happening to our patients from the onset of symptoms to diagnosis is on average 4 years. And Dr. Martin pointed out the results that can be gained by intervening within 6 months of diagnosis. So imagine the kind of long-term damage that's being done to our patients when it takes on average 4 years to diagnose people with psoriatic arthritis. I made a quick reference to our Board of Trustees yesterday. They approved a 5-year strategic plan that contains a lot of different elements in dealing with psoriatic disease, but one of the most important elements of that was we made a commitment as an organization to dramatically reduce the amount of time spent between onset of symptoms and diagnosis of psoriatic arthritis. Taking that, basically cutting it by 75%. And after listening to Dr. Martin's comments, I think we may have to go back and relook at our target and say maybe 6 months is the right number. But if we can achieve this over the next 5 years to reduce the time of diagnosis from 4 years to 1, imagine the impact that we can make on people's lives in mitigating the long-term consequences of these diseases. It will be our most comprehensive and expansive approach to psoriatic arthritis. It will cut across everything that we do. It will not only cause us to increase our research investment, but access to care issues, as we've talked about tonight. There's some terrific therapies on the market to deal with psoriatic arthritis. However, you have to get access to those. And the first step is getting patients diagnosed and then getting them treated and getting access to those effective treatments. And then again, on the side of research, our psoriatic arthritis project will be, one of our approaches will be to entice more scientists into the psoriatic arthritis community and hopefully improve treatments and one day a cure. We're going to focus in on 4 major areas. They are certainly not all inclusive, but most of our focus will go into, as I mentioned before, diagnosis, disease self-management, access to care, and then gaps in knowledge that really focuses in on the research, basic science, translational science, and ultimately leading to better treatments and cures. Okay, that's just a snapshot of what the National Psoriasis Foundation will be doing. We all have a role in this. Our clinicians on the panel, they obviously are dealing with these patients every day. Our friends in the manufacturing industry are developing tools that better treat these diseases. Our payers, at least in whether they be governmental or whether they be private, have a stake in making our patients' lives better. And as a patient advocacy organization, we certainly have a stake in creating an environment entirely. They just basically choose not to treat. What can healthcare providers and advocacy organizations like the NPF do to address this issue? And so either Dr. Van Voorhees or Dr. Martin?
Well, I think we all have a role in trying to address that problem, and it's huge. I think, let me start with patient advocacy groups. I think really what we need is the word to get out that there are new treatments and that there are people who want to take care of patients who have both psoriasis and psoriatic arthritis. I think very commonly patients may have had an experience that wasn't positive and they're fearful of going back, or they felt that a therapy was ineffective and it's just too disheartening to consider trying something new. Many of our therapies can work initially very, very well, and then after a year or two, they kind of putter out a little bit. And boy, you know, when you've had a big burden of disease and it goes away and you feel like, oh my God, I can do what I want to do. I can run, I can exercise, I can, you know, wear the clothes I want to wear. I could just feel comfortable in my skin. And all of a sudden the disease comes back. You can imagine how poor that feels to our patients. So I think the patient advocacy groups really need to get the word out that there are new modalities, that there are people who want to see them, and that that there's hope for their future and their response to treatment. I think what providers need to do is they need to understand that our patient, we need to keep that patient center, and we need to be sure that we treat to keep people so that their skin is clear and that their joints feel good. And I think the old standard of just saying, you know, it's just on your skin and, you know, just smear a little cream on it, you know, for someone with a more significant burden of disease, that really is, you know, that's so not 2014, you know, it's just not no longer an acceptable answer. So I think we need to do a better job amongst our I think we physicians need to do a better job amongst our fellow colleagues to make sure that either they're willing to treat these patients or that they refer patients to those who are. And if a patient comes in to see me, we also need to be very good about educating dermatologists that if a patient has symptoms, and I need to be asking them, how are your joints feeling? And that if they have symptoms that, you know, raise my question in my mind about whether or not this may be the one who has psoriatic arthritis, that we get them in the hands of good rheumatologists as well. So I think there's plenty of room for all of us to work to solve this one.
I think Dr. Van Voorhees has covered that question beautifully. I think if patients really understood that the psoriasis on their skin is a marker for something else going on inside the body, kind of like if a patient pops up with chicken pox, you know that something is serious going on inside that child's body and they get quarantined. With psoriasis, we're starting to view this as really a systemic disease. We're looking at it that patients with psoriasis, as we've mentioned, have increased risk for heart attacks, stroke, diabetes, chronic kidney failure, and as well as arthritis that can be debilitating. And I think if patients recognized early on that they are at risk for this, then that awareness might encourage more patients to seek help. They need to understand that the therapies that we have today are better and safer than the therapies they may have had 5 years ago, 10 years ago, when they just gave up and lost hope. And you have to remember, underlying psoriasis patients, these patients have a psychological profile that is really that of someone who is chronically depressed. And so many of them just give up. They suffer from a lingering depression. I mean, the photograph I showed you of the patient covered with psoriasis, would you walk around with a happy face? And if your joints hurt, I mean, you all have walked around with sore joints from sports injuries. You weren't smiling. And so it's really creating awareness. Yes, we have great therapies, but you have to get these patients into the doctor's office. And once they're in the doctor's office, it's our job as physicians to educate each other, to look for signs of psoriatic arthritis and intervene early, and to discuss with the patient that this is a systemic disease, that we have to be aware that if you are obese, not only will losing weight help your medicines, but it's going to also help reduce the risk of your heart disease and your risk for stroke. And there are ongoing studies that are looking at the effectiveness of our medicines to prevent stroke and heart attack in psoriasis patients. 50, 60, 70% higher risk, heart attack, stroke, sudden death. I mean, that's significant. And here, you know, all of you are familiar with a cholesterol number of 200. And if you go over 200, it's like, oh, maybe I should see my doctor and go on medication, right? And now that awareness has been created, and everybody knows their cholesterol score. Now everybody needs to know psoriasis. Thank you.
Okay, I believe we have a microphone for any of you that might have questions for our panel. Yes, could you please, when you're asking your question, identify yourself first and then go
Yes,
ahead.
Walter Alexander, U.S. freelance, P&T, Doc Guide, and others. Where are the levers for the access problem?
Well, I'll take a stab from at least the National Psoriasis Foundation perspective and then invite our panelists to comment. But, you know, access is a complicated issue in this country. And for our patients, the primary point of access, or the biggest challenge to access, is cost. And that's the primary concern of our patient community. Again, there are some very good therapies, as we've well established before, and not everyone wants to cover them. They're expensive therapies, and depending on your health plan, and that landscape is changing as we sit here tonight, at least in the United States, on being able to get access to these therapies. So, you know, from my perspective, one of the levers is getting access to those treatments, regardless of the cost, and having people have options of multiple options within a drug class is from our perspective one of those levers. I'll invite Abby or George to comment as well.
That's what I'm asking, is you have a patient whose insurance company has just said, sorry, you've reached your lifetime limit, and here's a patient who's going to have this disease for another 20 plus years. What do you say to them? And what are they supposed to do?
You know, let me say that, you know, you're right. It's making for some very unpleasant conversations in my office. So I can't, you know, I don't think any of us are prepared for really what you say in those circumstances. I think really what we're seeing, at least what I'm experiencing in my personal office since January, is that that it's become very much harder to get medications. I think, you know, the Affordable Care Act was intended to allow more patients to have health insurance, which sounds wonderful, and I think that's great. But I think what's happened, in fact, is that that there are very many more obstacles for us actually getting medications for these patients. So that there's more tiering, where patients have to have failed more things in order to qualify. Patients who've been stable on a drug for a while no longer can access it. Then somehow they need to try 3 more things before they can get it back again. So we're seeing just lots of hurdles. And I think that, you know, the public is sort of just beginning to understand this. And I think that it's creating a huge amount of disquiet amongst patients who have chronic diseases. And I don't think in the psoriasis community we're alone. I suspect that's true in all communities. I mean, of course, I know the psoriasis community the best. But I think our patients are frightened. I think patients who have insurance are scared they're going to lose it. I think, I had a patient just last week tell me, he said, gee, I decided not to retire because I don't want to lose my insurance. So I'm going to work as far as I can until the day I die, because then I at least know I can keep my insurance. So, there's I think there's a huge, there's always problems when a new policy gets put forward in healthcare. It always takes a little while for some of the snags to get worked out. But some of the issues here are not just snags. Some of the issues are our society's commitment to taking care of those with chronic diseases where medications are expensive. And we can help by defining outcomes better and showing, numeric scores. So we need, on the medical side of things, we need to develop those, and we are working very hard right now to try to come up with those numbers. I know the Psoriasis Foundation is involved in doing that, because I think we all recognize that without those numbers, we're a little bit like going to the payers saying, gee, please give our patients medicine, let's play nice, I think we need numbers so we can say, wait a minute, if our patient's number goes over a certain amount, then they qualify or they don't qualify. But I think we all need to understand that that patients who have chronic diseases really do require therapy, and that that we need to support them in that need.
I think that Dr. Van Voorhees has really given a great answer to that question. Let me amplify a few things. Certainly the uncertainty of the insurance debacle that's taking place and is disconcerting. What you have to understand is that at some point, Dr. Van Voorhees and I have sat down with numerous patients who find themselves without insurance, and then we have to look at resources for treating, in some cases, very severe psoriasis. What I want to talk about just briefly is that there's this notion that the pharmaceutical industry is this big, bad, money-gouging, Wall Street concerning industry. And in my experience, it's the opposite. They put on their pants or skirts just the way you all do. They have families, they have children, they have people who found themselves without jobs, without insurance, with severe problems, and psoriasis is one of them. They have compassion. They make decisions at pharmaceutical companies. Pharmaceutical companies across the board have a heart within them that beats, okay? And that heart are the patient advocacy groups that every company has. And many or most of these companies have created programs for those individuals who find themselves without their drug. And they have a heart knowing the severity of the disease and that patient needs drug. Now, those programs vary year to year, company to company. But we as physicians seek out the pharmaceutical companies, and probably right now I have 5 patients on therapy that is expensive, and they're not paying a dime because of patient advocacy programs within the pharmaceutical company. So you can't leave the pharmaceutical company out of the equation. They created the drugs to help people, and by gosh, across the board, they're there to help and provide drug when needed, in many cases, at no cost. It's sort of the in-between things, the co-pays and the people with insurance, and that's where it gets complicated. But there's no one prototype for what happens with or without insurance, or company to company. But I'll tell you, the companies do have a heart. And Dr. Van Voorhees has experienced it, and I've experienced it. And despite that all, there are patients who fall through the cracks for one reason or another. So I'm just, that's something the pharmaceutical companies, we look to them in many cases for help. Gentleman over there had a question. I'll field this one, Abby, and you can, yeah. Question, sir?
Alan Murray from France, Le Quotidien du Médecin. You've given us the global results of the survey. Did you observe significant differences between the countries you studied? Between France and US, for instance?
Yeah, I was actually really curious about that too. The answer is no. Really, it was more the same than it was different. And so that we can't just look at one health system and say, oh, well, maybe in the United States where we don't have that same degree of universality of health insurance, maybe that's maybe why we're seeing this problem of lack of access or lack of diagnosis. In fact, we see it quite similarly right across the board. And I think this really more speaks to the fact that psoriatic arthritis is hard to diagnose. It's often squirrely. People say, well, my joint is a little sore. The other thing is that, and this is really very remarkable, I hear this so often when I start a patient on therapy. And often I'm starting them on their therapy, of course, for their skin. And they'll say to me, and we'll talk, their disease will be substantial, and, I'll come back in and I'll say, so, how's your skin feeling? And they'll say, well, yeah, that's better. But let me really tell you, it's my joints that feel so great. And then they'll say, I didn't know they were hurting me. And if I had a nickel for every time somebody said that, we could, build another building. I think the fact is that when disease occurs slowly, oftentimes people become oblivious to it. We assume it's just, how many times people have said to me, I'm sure you've heard this too, they say, I just thought I was getting old. And I often think to myself, people will be 35 or 40 and they'll say, well, I just thought I was old. And I'm thinking to myself, my joints don't hurt. I don't assume my joints should hurt at this point. Why do others think that they ought to? But I think that when things occur very slowly and chronically, it becomes the new norm, and we just accept that as the status quo. So I think the fact that there's no blood test, I think the fact that things occur kind of slowly and chronically, I think all of those add up to the fact that sometimes practitioners are uninformed and, face it, oftentimes people come in and say, they stub their toe and they say their joints hurt, so that there's a certain amount of background noise where you don't want to assume every little aching complaint is truly a sign of underlying chronic psoriatic arthritis. But the end result is that it can be tricky unless you're paying attention to really understand that when that patient has that skin disease, that they may be at such higher risk for psoriatic arthritis. But one advantage we really do have, and this is why I think education really has such a great chance for success, is that the vast majority of patients, the overwhelming majority, will develop their psoriasis first. So that they'll be my patient for 10 years before their joints start to ache. So that's why we really, for the majority, there's a very small minority of people who will have their arthritis present first. So for the majority of people, if I can educate my fellow dermatologists, if I can educate my primary care doctors, if I can educate those of us who are taking care of their skin disease first, then I actually can at least heighten sensitivity when that patient does start to complain about their joint disease, that it might be actually something more substantial, and that our threshold for evaluating them, either by ourselves or by having rheumatologists get involved, I think has to be, heightened.
Okay, thank you, Abby. We're quickly running out of time, and I think I could invite George and Abby to stick around for a few minutes afterwards for those of you who have questions you want to speak with them one-on-one. But I want to thank all of you for joining us here this evening, and if you could join me in giving a round of applause to our panelists on this evening's topic. Again, thank you, and please feel free to stick around and ask questions of our panelists.